Good afternoon, everyone. I'm Dóra Demeter. My PhD topic is about nutritional therapies in inflammatory bowel disease. I work in the military hospital at the gastroenterology department. My vision is to make nutritional therapies as well known and used in medical field as they're needed. My mission is to provide better nutritional care for all. My three topics: first of all, it investigates the exclusive enteral nutrition. Second one, the effect of GLP-1 analogs. And the third one is the nutritional status of IBD patients. My first topic, investigating the effectiveness of exclusive enteral nutrition on surgical outcomes in inflammatory bowel disease. Why is this important? Nearly 5 million patients suffer from IBD worldwide, and you can see it in the graph that the prevalence is dramatically increasing. In Hungary, it's 55,000 patients. In the first 5 years after diagnosis, nearly 22% of patients receive surgery, and in Crohn's disease, this complication rate is around 20 to 30%. Why do we use exclusive enteral nutrition, or why do we want to investigate this, even though it's usually used in pediatric practice? There are some very promising results about reducing postoperative complications after exclusive enteral nutrition, or there is even cases when we can cancel the surgery. Our aim is to understand whether rehabilitation of exclusive enteral nutrition in IBD patients are safe or effective. Our clinical question: does exclusive enteral nutrition before bowel resection improve the surgical outcomes in IBD patients? We will investigate adult IBD patients who need elective surgery. Our intervention would be exclusive enteral nutrition and the standard of care. Our comparatory would be no dietary intervention, only the standard of care. Our outcomes will be the surgery implications and the infection rate. Our hypothesis is that exclusive enteral nutrition before surgery can improve surgical outcomes. The clinical implication would be decreasing postoperative complications. Our key articles here presented, they all have promising results. 2 of them had the intervention of 4 weeks of exclusive enteral nutrition. 1 of them had 3 months. Here we can see the search key. The first domain focuses on the rehabilitation, the second one on the disease itself, and the third one on the therapy, nutritional therapy. We conducted our research in 3 databases, in PubMed, Embase, and Cochrane. Our previous meta-analysis, we found only 1, but it only focused on the infection rate as an outcome, and it was published in 2024. There were no prospective registration in this topic. Here we can see the flow chart of our progress. We are currently at the stage of title and abstract selection. Here's the other flow chart. We can see that we are on the second half of the title and abstract selection, and then we are currently, then we will follow it with the full text selection. Our second project is investigating the effectiveness of GLP-1 analogs on disease activity and body weight in obese inflammatory bowel disease patients. Currently, we still think of IBD patients as malnourished patients, but gastroenterologic treatment is so effective that now they are gaining weight and they are becoming obese as well. So around 15 to 40% of IBD patients have obesity nowadays. In ulcerative colitis, each incremental increase is BMI with 1 increases the hospitalization rate by 3.4% and the surgery rate by 5%. Creeping fat tightens the strictures in Crohn's disease. Between 2010 and 2019, only 2.8% of eligible adults with IBD and obesity were prescribed any anti-obesity pharmacotherapy in the last 10 years. Our clinical question: are GLP-1 analogs safe and effective in obese IBD patients for weight loss therapies? Obese IBD patients would be our patient pool. Intervention would be either semaglutide or liraglutide treatment. The comparator would be no pharmacotherapy weight loss, and the outcomes would be weight loss, which is at least 5% of the original body weight, and disease activity. Our hypothesis is that GLP-1 analogs are safe and safe therapy for obese IBD patients. the clinical implication would be to provide a better and effective treatment for obesity for IBD patients. We would include patients who are at least, the BMI is at least 30 or higher, and they are in remission. Their IBD is in remission. We would exclude everyone whose BMI is not reaching at least 30 and the disease is active. Our third topic, nutritional status in IBD patients undergoing biologic treatment. All guidelines suggest that we should take care of the nutritional status of these patients and that malnutrition is a very high risk for these patients. However, we don't exactly have data on the prevalence of the obesity, the malnutrition, the sarcopenia, and the sarcopenic obesity of this population. We are lucky enough to have 1,000 patients, estimated 1,000 patients undergoing biologic treatment in our hospital, and we also have the tools to measure their body composition. So we want to do all 1,000 patients have a body composition measurement and then do a study about this. The strength of this would be that it's very relevant. It would be a baseline for future studies where we could analyze subgroups based on dietary activity, therapies, previous surgeries, and amount of resected bowel. And also, it would be a very good database. However, it's a lot of time and it's a lot of work. As summary, I want to summarize that in the first study would be about exclusive enteral nutrition, the second of the GLP-1 analog, and the third one about the nutritional status of IBD patients. I want to finish my presentation with the words of Albert Szent-Györgyi: research is to see what everybody else has seen and to think what nobody else has thought.
First of all, congratulations to your presentation. My question is that what is exclusive enteral nutrition means? Can you explain it?
It's therapy where the patient only receives formula as calorie intake and they are not allowed to eat anything else, like water and only formula.
Okay, thank you.
And what is the mechanism of the benefit? So why
it changes the microbiome and it's relieving from the work of the bowel because it's already well-prepared nutrition.
And what are you going to look at in the first study, so in the exclusive enteral nutrition study as in outcomes?
Complication rates and infection.
Will you not look at the microbiome numbers, if there are numbers? So you see, so what I'm trying to say, you will collect data on how the patients get better, how they don't get better on this treatment, but if there's data on the microbiome in these patients, will you look at that?
We would include, however, based on our current experience with Titan and abstract selection, there are not too many articles to include, and even less which would even mention the microbiome. But we would not exclude that information.
Microbiome is everything.
Exactly.
May I ask that, do you use or do you give any probiotics for your patients besides the exclusive enteral nutrition?
No, the current guideline of ESPAN doesn't recommend my probiotics for IBD patients.
Okay.
So I was interested to know, is there any specific mechanism of action behind those drugs that made you investigate them on IBD-related patients, this kind of patients?
Which project are we talking about?
The one that you use, liraglutide and semaglutide, this kind of drugs, that made you include them and exclude others, to be much more specific.
Well, we included the ones which are available in Hungary, first of all, and which we can prescribe for patients without diabetes. Yes.
Thank you very much.
You're welcome.
Congrats on your presentation. I just wanted to ask about your first meta-analysis project. Do you think that 3 weeks of nutrition and 4 weeks of nutrition are the same clinically, so that they can be put together?
No, we want to make a subgroup analysis based on the length of exclusive enteral nutrition.
And based on your current status of your title selection, do you think it's possible that you have enough articles to do a subgroup analysis?
Yes.
Yes? Okay, thank you.
And you mentioned you analyzed more than 1,000 patients. And do you have a data how many of these patients, based on the in-body results, have a sarcopenic obesity or around percentages?
We did not start measuring them, but based on experience, many.
Just one short question. Will you collect data on physical activity of those patients? Physical activity?
Yes.
Because I think this is also an important question.
Yes, thank you.
Just related to this question, is this part of your prehabilitation program, physical activity also, not just the nutritional part?
If it's an elective surgery and the patient's compliance is high enough, then we do encourage them to do physical activity. It's not always happening.
Yeah, because a complex prehabilitation program has to include the physical activity, nutrition,
Yes.
psychological
Yes.
help and evaluation as well. Probably these three works together most efficient way.